one of the practice liaison officers for NOTS LMC. So today we're joined by Beckie McConville, Head of System EDI for the ICS, going to be talking about some available training for dyslexia for practices. And then we're going to have the Deputy Directors for Primary Care Transformation, Stewart Newman and Sall and Andrew Beardsall, giving a bit of an update, talking about some of the engagement they're going to be doing at these sessions that we hold on a weekly basis. And then we have Hazel Buchanan talking about the winter vaccine programme. So Beckie, I'm going to hand straight over to you, if that's okay.
Perfect, thank you. I'll not keep you very long. It's kind of a swift overview and then to gather some of your thoughts and ideas about how we can roll this out best across primary care. So hi, I'm Beckie. As Emma rightly said, I'm head of System EDI at this point in time on a secondment from Lincolnshire, and due to move back to Lincolnshire at the end of August. So really keen to share this dyslexia training with you all before I depart. So just to set the scene slightly, there was a pot of money that was made available to Nottingham and Nottinghamshire from the Be Well Midlands Fund, and it was £20,000. And there was an identification before my time to ensure that people could access dyslexia training and assessments. So working with the chief exec of the Dyslexia Association, we explored how we could get the best bang for our buck, really, in how can we make training accessible across the entire system, and how can we leave that legacy behind to ensure that people were able to access assessments. So that's how it started. We did some negotiations, and what we came up with was, from the £20,000, it was going to be really difficult to offer full assessments about dyslexia across the whole system. I think it would equate to about 10 assessments maybe that we could offer, and we didn't feel that was reflective of what the entire system would need. So therefore we worked on some other alternatives, and this is what I'm going to present to you today. So the chief exec kind of spoke to another partner organisation called 10 to 3, and they've worked together before, and they've created as a set of vignettes, there's going to be 9 of them, looking at neurodiversity and dyslexia incorporated within that. So they're going to be available for anybody across the system to access. In an ideal world, we were hoping to have one front door where everybody could access that facility from just one front door. However, the technicalities of memorandums of understanding, governance, sharing data prove really difficult. So what we're having to do is work with the organisation called 10 to 3 to work with different parts of the system to make this training accessible for all. It's essentially 9 vignettes, and they're about 3 to 5 minutes each, so they're not particularly onerous. And the idea is that you could use them as a manager to get some insight about what it might be like to work with somebody who has dyslexia, or you suspect may have, or it may be a tool for somebody who suspects they might have dyslexia to be kind of going through themselves to identify themselves as having some of those issues that are identified within the training suite. So my ask for you, and I'll put it in now and come back to it at the end, is we've been working with various organisations, and the option for people so far, because it's got to only be available to staff and not the public because of the licensing, is could we host this for primary care in a place that you could all access it? That's a question. Other organisations have gone through using their learning management systems, or alternatively using an intranet, so that you'd be able to just have staff accessing the facilities on a platform. I'm going to post that there, come back to you at the end with that one. On top of that, we were looking at how we could also offer training across the system. So some training was offered to the EDI leads across multiple organisations to look at what would reasonable adjustments look like, how does it fit within the Equality Act, and what could our cost-effective solutions for staff be, because many of their experiences with the Dyslexia Association was that people would take on really expensive tech-based solutions that probably didn't help the staff very much at all. So we've done a training session on that. There's 12 people across the system trained in that particular element. So we'll ensure that those names go on the web page and the platform so that everybody can access. Oh, I should have told you what's on the neurodiversity suite. So there's multiple videos. They're like animated videos, vignettes, and it talks about that we're all neurodiverse, but we're not all neurodivergent. Talks about the challenges. There's a section on inclusivity, some neurodivergent conditions, and there's some explanation around that. The race and neuro-inclusive talent, growing and winning neuro-inclusive organisations, managing performance, employer relations, and managing change. So there's a big suite in there, and they're set up so you can access one or all of those. So you could sit and do the whole lot in an hour, or you might just want to grab 5 minutes and look at the ones that feel relevant to you. The next element that we've got there is some accessibility to have some access to screening tools. So it's not the full dyslexia assessment because they're incredibly expensive. But what we are offering is across the system, there's 100 dyslexia screening tests available for people across the system. It's an online programme which basically looks at multiple strands for the person taking the screening tool. It's an online test tool, and it actually can be completed in full within an hour. Or if you wanted to do that, you get a login detail and you could do a couple of sections at a time. And they will look at things like vocabulary, memory, sequencing, visual skills, verbal skills, processing skills, about reading speed and comprehension, ability to speed type, memory and accuracy of recall, spelling, punctuation and capitalisation. So what the person will get at the end of that is quite a comprehensive feedback sheet that will talk about where the individual might need support and adaptations, but equally where the person may have significant strengths that they could use within their own role or within the organisation that they work. That said, we've only got 100 of those available across the system. So what I would suggest is that we're kind of saying on just roughly about 10 of those assessment tools across each organisation. So that would be 10 for you guys to use if you felt there were individuals in your system, in your areas of work that might benefit from having a screening tool. Now, what it won't do is give them a dyslexia diagnosis, but it will give them an indicator of whether the likelihood is that they would have dyslexia. And in relation to the Equality Act, it does mean that then you could use this information around reasonable adjustment. So it's kind of that midway position that will help support somebody in their work life to be able to access the most relevant provisions for them to enable them to function well at work. So that's essentially whistle stop. We've got the 3 elements. We've got all the training vignettes. We've done this EDI training for our partners across the system to ensure that 12 of them have done the dyslexia training around reasonable adjustments. And then also we've got these 100 screening tools that are available across the system as well. Now, what I would have said to you is just contact me if you've got any dyslexia screening that you would like to refer forward. But what I might do, Emma, if it's okay with you, is share directly with you the link of the Dyslexia Association, given that I'm going in a few days' time and I don't want you not to be able to access that. So I suppose my big question would be, where can we put this training for you guys that makes it accessible to you? I had thought about NAF and Phoenix maybe being part of a solution, but I figure it would be really interesting to hear where we could pop this for you so that you and your teams are able to access it. The training's really useful. It's been developed by employment lawyers and training professionals, so it should be really relevant and up to date for quite some time.
Thanks for that, Becky. I'm just going to invite James into his hand up.
Hi, James. Oh, you're on mute.
Sorry, I obviously double clicked. So hello. The obvious place is TeamNet, which I and somebody else has also put in the chat.
Okay.
So TeamNet is just the access platform that all GP practices have got access to, where we disseminate information and training.
Okay. And is that just Again, I'm going to be
Yes.
numpty because tech is
Yes.
not my thing. It's just
It is
accessible
just
to staff.
GPs and practice staff. Nobody else can get on there.
Marvellous. Is there, this will be the next question, is there one key person that I could have that conversation with to enable that access for all of you?
Yes. I'll try and
Yes.
remember who it is, but they're
Lovely. That's
yeah.
great. Super. Thank you.
I can give you that, Rebecca.
Stuart. Yeah, Stuart. Thank you.
Great. That's super. Thank you. Well, that's given me a really quick solution then. If you have got a space for us to be able to upload that, how it's worked in other organisations, it's just been literally a 15-20 minute call with that person who Stuart's kindly said he'll share with me, work out what the infrastructure looks like and how compatible it is with the 10-to-3 delivery option. And then it's we're just waiting for one signature from the ICB to sign that off. There's a memorandum of understanding just to say that it'll be shared with staff, not with the public, and then that's you all good to go. And we're going to have access for that indefinitely. So it's a good training resource for quite a number of years for us.
Brilliant. And then once staff have done the training, or they maybe identified areas that they need a bit more support with, or the reasonable adjustments, is that those 12 people that you mentioned, would they approach them for that support?
Yeah, I mean, obviously you might have that local conversation at place first, and you may be able to resolve that. But if there's some issues that you're thinking, oh, I'm just not sure about this, then actually you can contact those people as your experts in the field. Yeah.
Brilliant. Thank you. Andrew?
Hi, Rebecca. Yeah, I've just checked. Hiya. It's Fiona Dawes who you need to contact. She sort of leads on putting things onto TeamNet. I can drop you
an email, do you? Yeah,
I can send it to you, no worries. Yeah.
Perfect, that's great. And then I can get that sorted for you within the next kind of week or two, and then you guys should be ready to go.
Thank you. I'm just seeing Khalid's put something in the chat. Khalid, did you want to come in and expand on that?
Yeah. Did you say the assessment, once we've been trained, takes about an hour to go through?
Yeah, there's 9 vignettes, you can do them. They're like
no, I'm not talking about the training. I'm talking about when you see a patient and you and in the early stages, you want to do a quick assessment.
So this particular piece of work is just focused on staff, and I'm really sorry I didn't make that very clear at the beginning.
So it's just staff training.
This is about your workforce.
All right, that's fine.
Accessing for your workforce. Sorry, I wasn't very clear on that. Not used to you guys as an audience, more used to other colleagues. Apologies.
So yeah, so if you have sort of a staff member that's maybe struggling and that needs trying to identify what additional support they may need, this is sort of where they would go.
Right, that's fine.
Fabulous. I've got the email there. So Emma, are you happy if I use you as just a secondary port of call, so that when I leave there's a definite flow and it doesn't drop off a cliff?
Yeah, no, that'd be brilliant. Thank you.
Perfect. And thank you for your time today. I can send you through a PowerPoint if that would be useful. I'm having some Teams issues this morning where it wouldn't connect. But if I share that through, Emma, then obviously people that weren't here can also access that as well.
No, that'd be brilliant. Thank you so much.
Fabulous. Lovely.
Brilliant. Well, thank you for joining me.
Leave you to it. Thanks ever so much. Have a good day. Take
Brilliant.
care.
Thanks, Becky.
Bye-bye.
Okay, I'm going to hand straight over now to Stewart Newman, the Deputy Director for Primary Care Transformation.
I think Sim's actually picking this up, Emma. But to
start is she? Okay.
Yeah, Stuart can join in when he feels he'd like to after his week off. So you've got me and Andrew also today. I'm just going to do a quick screen share. So thanks for having us. Lovely to see so many of you here. Emma, just let me know if you can see that first slide, ICB Primary Care Transformation. Is that visible?
Yeah, thank you.
Amazing. All right, fab. So for those who don't know me, my name's Sall and I am the Deputy Director for Primary Care Transformation, as is Stewart Newman. And I'll let Andrew introduce himself when he comes in towards the back end of this presentation. So what we're here to do really is to give you a bit of an update as to the formation of our team and the structures linked to places and primary care. Give you a little bit of information about our roles, key areas of kind of responsibilities, and then we'll open it up to any questions really. So a bit of a recap. I'm sure you're all aware, but back in November last year, the structure of the locality teams was reviewed. This was as part of the work to reduce the ICB running costs, but also with the aim to kind of structure the team to meet the evolving needs of the organisation and our place partnerships and wider NHS. So previously, as you know, the locality teams were split into 4 places and carried out a combination of primary care support and transformation alongside broader place-based partnership work across sectors. Now, the structure that I'm showing you here is the formation of our new teams under the Integration Directorate, headed by Victoria McGregor-Riley. So what the review did was separate our key functions into 2. So we've got ICB-led primary care, contracting, commissioning and transformation. And then we also have the broader place-based working with local authorities and other partners. So following a good practice consultation, the new structure was approved and these roles were put in place from April this year. So underneath Victoria, we have 3 directors. So the first one being Victoria Callahan as PBP director on an interim basis, whilst Michelle's still off. And then Caroline Goulding, that's been appointed as Associate Director for Transformation, who will be overseeing the Frailty and Long-Term Conditions team. You can then see on the right-hand side that you've got the Primary Care Contracting and Commissioning and Quality team, which is Esther and Lynette's team. And then circled in red is a Primary Care Transformation team where myself, Stuart and Andrew belong. So I'm going to zoom into that so you can see the makeup of our team. So headed by myself and Stuart, we have Andrew Beardsall as Head of Primary Care Transformation. So Andrew remains the conduit between the ICB and Bassett Law for consistency and obviously retaining that knowledge, but also picking up wider Nottingham and Nottinghamshire work streams. We have a very experienced senior transformation manager for primary care, Jackie Moss, who many of you may have had interactions with. She remains our link for South Notts, as well as picking up set work streams across the patch. And we've recently appointed to our 2-year fixed term vacancy because of a secondment. We've appointed Claire O'Mara, who currently works with Mid Notts Place. So she'll be retaining her links and relationships with Mid Notts, as well as supporting me with the Thriving General Practice agenda for the city. The 2 blobs you can see in red are our 2 current Band 6 Primary Care Transformation Officer vacancies, which have gone out to advert, and we are currently shortlisting, and the interviews being led currently by Andrew and Claire O'Mara. And then Jenny Hill is our latest appointment as our team administrator. The 2 blocks you can see on the left greyed out because they're not formally part of our structure, but we do work very, very closely with our head of Primary Care Network Development, Rachel Rees, and our PCN Development Coordinator, Sharon Geggy, through Matrix Working. A little bit on our team objective and what we're set out to do. So our key objective really is to provide strategic leadership in the development and delivery of both nationally mandated schemes, such as Modern General Practice Access, General Practice Improvement Programme, just as a couple of examples, along with locally determined transformation initiatives across Nottingham and Nottinghamshire primary care. Primary care transformation schemes are also led by this team with close support from contracting and all 4 place teams. So we work really, really closely with not just the wider directorate, but also with other directorates across the ICB. I'm going to move us on to the functional responsibilities of our team. And what I've done on this slide here is tried to chunk them up into 3 key programme areas, because there's a lot to digest. The first pillar is how we support the primary care strategy and deliver set schemes. So one of them is pretty well established, is the primary and secondary care interface. There are other mobilising primary care initiatives at place level that are going to be unique to each of the places. There's a digital strategy that we're supporting, maximising our estates, looking at models of care such as on-day service, and the safe working agenda that we're working really closely with and in partnership with the LMC on, and then the enhanced services delivery scheme. So they're key examples of the programmes that we're supporting under that pillar. Then we have areas of work around that directly improve primary care access. So one being modern general practice access models and the transition funding that's attached to that, and the general practice improvement programme, otherwise known as the practice level support offer. So this is just a bit of a reminder, really. I thought it would be opportunistic for me to just let you guys know, as a polite reminder, that we are at the back end of our phases for rolling out the improvement programme, which has had made significant improvements across practices across the country. And also locally, we've had comments from local practices saying how much it's been transformative and life-changing for practice staff. So we really, really encourage you to consider, if you haven't already, signing up for the webinar is looking at encouraging take up of the final phase of this programme. It's a 6-month programme, and it's the final series for this financial year. So the deadline for sign up is the 20th of September, but I would encourage you all to get in contact with our team if you wish to obtain any further information. And on that, we've got a separate slide set, so I can share that with you all after this meeting, if that helps. The third area is referral optimisation. So referral support service sits currently with our team as well. And then key primary care transformation areas, we're holding on to, for the foreseeable, the enhanced health in care homes area of work, which is direct enhanced service, and community pharmacy elements as well that we support. With regards to practice queries and OPAL reporting, historically, and I guess really up until recently, our place teams have been holding the ring on that and responding directly to practices with OPAL and other practice queries, but that responsibility now sits with our team. And then the final pillar is what I'm calling it, is comms and engagement and training. So our team are holding the ring on primary care, ICB, comms and engagement strategy, and the rollout of our engagement events, along with PLTs. I'm going to move us on to the next slide, which tells you a little bit more about the comms and engagement work. So what we've done so far is undertaken a series of face-to-face engagement events, so the ones that were held at each place. Use the feedback from those events and via our surveys that have gone out as well. And as a result of that, developed a guide for practices on how they can navigate the structures within the ICB, key contacts, who to contact for which issue. So that should have gone out to all practices last week. Next steps then, based on the feedback that's been received to date, is we're here today, and that was as a response to some of the suggestions that have been put out. So our kind of desire really is to continue attending LMC webinars, using it as a platform to engage with practice managers on a monthly basis. Sorry, I thought that was a question. Continue to attend these touch points on a monthly basis, where you'd get an update from ourselves, and along with another ICB rep, and I understand we've got Hazel here today to talk about acronyms, just to give you an example. So hopefully we can do that on a rolling programme. Also, a rolling programme of quarterly engagement sessions that could be held at the beginning of PLTs at each place, both face-to-face and virtually. And then really to continue to seek feedback from practices and respond accordingly. In our guide that we've sent out to practices, we've also put, I don't know if you've clocked, but at the footnote, what we've said is that we are absolutely open to having one-to-one conversations. It doesn't need to be that you've got a specific issue. If you feel that you'd benefit from having contact from a member of our team to get to know us, to get to understand our priorities and how best we can work with you, then we are more than happy to schedule time out and visit you in practice. So I'm now going to hand over to Andrew, who's going to talk you through the work he's leading on around PLTs.
Thanks, Sim. Yeah, I'm Andrew Beardsall. I'm Head of Primary Care Transformation. A lot of you won't be very familiar with me, but I've worked in Bassett Law for the last 20 odd years, so a few of you will be very familiar with me. But I'll be working across Nottinghamshire from now on certain things, so please feel free to get in touch. I'm here to support. One of the areas I will be, as Sim said, helping to support is PLT and the development of that. There'll still be the existing education forums available in all of the different places. So either way you want to feed into things, it can either be via me or via those existing forums, and I'll be attending them anyway. So we'll bring everything together. In summary, I thought people would be interested in a bit of an expansion of where we're going with PLT. Pretty much a continuation of the current arrangements. We're looking to extend the PCDC contract for 3 years. There's a paper currently going through the governance systems of the ICB that I'm pretty confident will be successful. And PCDC have already said that they're willing to also continue. So pretty much the same in terms of the structure of it, same number of sessions, same balance of face-to-face sessions versus virtual sessions versus in-house sessions. So not a lot will change in terms of the structure. But as Sim mentioned, we're also looking to go back to the future a bit in terms of having some more ICB engagement sessions at the front end of PLT. A lot of CCGs did this and called them members meetings, and the feedback we've had is that they're quite missed. So the intention is to do those at least quarterly, and also a little bit more on request when particular things need to come. It might be the executives quarterly, it might be certain ones of us on particular issues, but we can certainly fit that in. I'd be interested to know particularly from practice managers and non-clinical staff, that's an area we'd like to develop. Would you like parallel sessions? They might be short ones, open to all, recorded, I would say, because I know your PLTs aren't always aligned in terms of timing, but if they're particularly successful, if we hold them at a particular place, then we could repeat them across different areas and we could organise those for you. So I put some examples there we've done before in Bassett Law, but we had fairly small numbers of practices, so it wasn't always easy to organise. Things like software demonstrations for some of the online services that we're getting, GPIP that Sim mentioned earlier. And we've had the odd request in the past to do a bit of a briefing on vaccination campaigns and the rules, etc., which we can organise for you. So just let us know what you want. I'll put my email into the chat and please feel free to get in touch, or as I say, your local PLT education forums will still be going. And I'd like to feel this is part of the PCDC contract, is to provide education for non-clinical as well as our staff. So I think we would like to work on widening the offer. So again, please send ideas, talk to your R staff, talk to your receptionist, your head receptionist, whoever might want a bit of a wider offer via PLT, so we can make it more inclusive for all. And yeah, look forward to working with you. Cheers.
Thanks, Andrew. I'm going to stop sharing the slides now. Also conscious of time, Emma, it's 12:30, and I appreciate that Hazel is joining us for the last slot. But is there an opportunity for a couple of questions at all?
Yeah, it looks like there's some comments in the chat around practice networking for medical secretaries, so they could sort of share learning or issues that they're facing, and feedback that previously non-clinical sessions have been poor in quality, but that parallel practice manager sessions are good, but only if the team have good quality training, as we're often as PMs delivering or chairing for training they've arranged in-house.
Thank you. We'll take that on board. Sorry, Andrew, were you going to come in?
No, I think that's probably fair comment. I suppose if we are doing it as more of a combined effort, we're trying to get a bit of uniformity across Nottinghamshire, we can probably get in better level of sessions, I would say. I don't know, I've not been involved in the Nottinghamshire sessions themselves, but I think that's a fair thing to take on board. Yeah, we need to make sure if we do run things that they're of a decent quality, agree.
Yeah.
And I think there's just an ask about vaccines updates no longer being provided. I think they previously were, and it's been stopped. So if there's anything that we could do to look at that as well, I think practice would appreciate that.
Really helpful comments in the chat. We'll definitely take those on board, but I can't see any hands up for any verbal questions.
Just on the face-to-face, sorry, just on the face-to-face sim, at the moment we've put in the ability within the PCDC contract to have at least 2. It's always a mixed opinion on whether online sessions, because they're often very convenient, versus face-to-face, which is more interactive and actually often more popular with the presenters doing face-to-face sessions. So I'm always interested in that balance, but that's what we've put into the PCDC contract that they need to support too. We can always work with them if we want to expand that further going forward, but that's what we've currently put in their contract. Or if that's considered to be too many, then we can always say to PCDC we'd refer it online instead.
Thank you. James, then Khalid.
Yeah, I was just going to develop my point slightly. Is that there are certain things that are presented that just lend itself better to a face-to-face discussion, and they don't work very well as just a download of some specialist information. So I suspect actually it's not as effective, even though we might get high attendance at them. So there is a balance, and I would have thought for certain, they almost need to rate what the subject is and what we're trying to get across, rather than just specifically the frequency. Would be my thought. But yeah, thanks.
Fair point.
And just to reinforce that, Andrew, don't underestimate the value of just coffee break networking between colleagues during the face-to-face meetings. It's really useful learning from each other, as well as the clinical tutors who are giving us teaching sessions.
I agree, Khalid. I think that the face-to-face sessions are very valuable, and that's exactly the point. It develops a bit of a community of interest, that kind of thing. So I personally, I mean, I've organised PLTs now for 22 years, and I've always felt that one of the values of them was exactly that, coming together. And I think a lot of presenters would also agree with you in terms of the sessions go better when they're face-to-face. But for every person who's in favour of more face-to-face, I get the same amount of kickback from people who would rather have more online. So we'll try and strike that balance and work with people on getting that right, I think.
Well, thank you all for coming along today. I think we hear repeatedly from practices that they want more FaceTime with ICB colleagues. They don't know who to contact anymore. So it's great that we're getting that now, and the contact lists are in place for practice to know who to go to. So thank you for coming along today.
Thanks, Emma.
It's great. Yeah.
Thanks, everyone.
Brilliant. Okay, Hazel, if you're there, I'll pass to you, please.
Yeah, thank you. And I've just got some slides to share. So let me just open those and then I'll. So am I sharing that as slideshow?
Not as
there.
Yeah, they're brilliant. Thank you.
Okay, thanks. So I'm here to talk about the Winter IMS and VAX programs. My name's Hazel Buchanan. I'm Associate Director of Health Inequalities and Clinical Strategic Programs in the ICB, and have a lead role for health protection. I'm not an IMS and VAX clinical expert, so it may be that today we take away a number of questions, but hoping to give you a bit of an overview of how the winter IMS and VAX programs are fitting together. We're also supported by Kelvin Lim, or Dr. Lim, I should say, who's our clinical director that I'm sure a number of you know. He's taken on a role as clinical director for IMS and VAX. So this year we do have a new vaccination, RSV, alongside flu and COVID. So I'm just going to quickly go through each one of them. So the RSV immunization program starts from the 1st of September. It includes two programs. One is for older adults and adults aged 75 on or after the 1st of September are eligible for the vaccine. And then there's a catch-up campaign with this being with this being a new vaccine. This isn't, I recognise this isn't a seasonal vaccine, but obviously there's the pressure to get from national NHS England to get the as much done around on the catch up for the older adults as possible before December. So this does sit alongside the flu and COVID programs. There's also a program for pregnant people to protect infants, and that is being managed through maternity services. And our trusts are looking at how they operate this so that they're able to do the vaccinations around 28 weeks of pregnancy. GP practices can do opportunistic vaccines, and I know it's been raised about how do you share the information around whether the vaccine's been done or not. And so there are some challenges, but it's how we work through those in this early stages of this vaccine being introduced. So the vaccine is Pfizer Abrysvo, or however you say it. It's presented as a single dose pack, and the reason I'm mentioning this is because I know there's been some concerns about space in fridges with this also operating alongside the other vaccination programs. The vaccinations are centrally purchased and provided free of charge, and ordering is through Inform, and you can order the vaccines now. I believe it's recommended that there's 2 weeks of you order 2 weeks of vaccine supplies, and that's predominantly because of the space required for the vaccines alongside others. For older adults, the vaccine can be co-administered with shingles and pneumonia, but the recommendation is that it's not administered at the same time as flu and COVID. Oops, sorry, I had email today to say that RSV has to be done first. As far as I know, the RSV doesn't have to be done first, but the guidance is that RSV isn't done at the same time as flu and COVID. It does say that if you feel like there's no opportunity to get the person back in to do flu and COVID as well as RSV, then the decision may be made to give the vaccines at the same time. Pregnant women can have the vaccine co-administered with the flu vaccine and can be co-administered with pertussis as well, which we've got to focus on at the moment. Sorry, it's just not. So flu, oh, sorry. I know you know all this, but just to say that flu starts 3rd of October, so later this year, and that's for all groups except pregnant women and children and young people, which is starting the 1st of September. Flu, as per normal, is being delivered by GP practices and community pharmacists, and the cohorts are the same as they have been previous years. I think just to mention on flu, last year we were down across all cohorts. So there'll be a real focus on how we increase uptake this year and get that back up to previous levels. So the COVID program is starting the 3rd of October alongside the flu. It is being delivered by PCNs and GP practices, and and community pharmacies. So within Nottinghamshire, we have 107 community pharmacies signed up to do COVID and 10 PCNs. So when you look at a map, we have got cover, really good cover through the community pharmacies across Nottingham and Nottinghamshire. Where we do have some gaps is where we don't have the PCN cover, and so don't have cover for care homes and housebound. So what we're looking at is options around covering those areas, and in particular Nottingham City and Mansfield, where we have the biggest gaps. The cohorts are adults aged 65 years and over, residents in a care home for older adults, individuals aged 6 months to 64 years in a clinical risk group, and frontline NHS and social care workers are included. They weren't in the JCVI guidance, but we're due to have a letter shortly from Department of Health and Social Care and NHS England to say that they are frontline staff are included in the COVID campaign. But we just there's some questions over how this will be delivered. So the COVID uptake for spring summer 24 was actually down on where we have been previously. So again, it would be good to get the uptake, really focus on that and get the uptake increase for autumn winter 24. And that was it. So open up for questions.
Thank you. So there's some questions just in the chat that I'll just quickly go through. Cadid's put a comment in about not much training being available for the RSV. Do you know if there is any training or what training is out there for practices?
Yeah, so there's been a number of webinars that have been put on through NHS England for the RSV vaccination, and quite a few comms. So I can see if there's more webinars coming up, or I'm sure those are probably recorded and we could see how can access the webinars.
That'd be great, thank you. And then a question around maternity services. Are they definitely doing the RSV? Private practice has been told that recently they can't administer the new pertussis vaccine, so they're worried that it'll also be pushed back on the RSV.
So maternity services are definitely doing RSV. No, and they've been doing pertussis, but so they are most definitely doing RSV. There are definitely some challenges for them with it being at 28 weeks. So they're looking at how they can do that most effectively. I think because this is an ongoing vaccine, so it's not just seasonal, it's how are the processes ongoing. So they are also looking at what are the opportunities to do the RSV in the community. So we're working on them on what the options are around that. But yeah, definitely they are starting to do the RSV.
Thank you. And there's a comment or question, and there could be issues with asking GPs to run searches for other providers for no funding. So I think this is for the COVID and flu where practices haven't signed up. This would fall under one of the collective action headings of not doing unfunded work.
Yeah, I would hope there wouldn't be any issues, because this would be the way that we're going to get housebound vaccinated. There's the risk that they wouldn't be vaccinated, which I think has bigger implications. But we're hoping to help by providing the template to do the search. It'd be interesting to know what it would be, what the actual cost would be to a GP practice if they wanted to provide that. But doesn't, so if anyone wants to raise that as a concern, we're happy to take it. But I would hope if we've got your, since we've got support to do the COVID vaccination and we've got care homes and home care covered, that practices would be able to support this.
James, did you want to come in on that at all?
I can do. It's just there's a, as you know, there's just a significant campaign for GPs to not do unfunded work as part of the collective action, and it just feels like a really obvious thing to hold back. So I don't know what the opinion of general practice as a whole. I'm just raising it as an issue, and that people be looking to not do unfunded work. So looking to fund it might be a solution. But don't know.
I guess since we need to start the COVID program 3rd of October, it'd be useful to know what level of funding are you talking about? Because it's it would be the admin staff doing a search that's normally done. It must be a routine practice through primary care.
But it's only routine if you have the time to do it. So I don't know, there could be a nominal fee for an hour of practice staff time or something. I don't know. It could be nominal, but it was just an issue that I'm only raising it really because I don't want it to get to the point in a month's time when nobody responds because we haven't considered it. And it might be we just need to ask people if we're all happy to do it. And it may be we all are. I'm just rather to find out ahead of time was my thought.
Khalid?
Hi, Hazel, just supporting what James just said. I know it's not a huge amount of work, but you'd be surprised if you sat in general practice for a week, how little bits of extra work from different departments soon mounts up in general practice. And so, you know, every department says, oh, this is not really very extensive work, but it soon mounts up. And if we ask this reciprocal question of secondary care or ICB staff, can you do a bit of this? Can you do a bit of that? Secondary care usually say, we're not funded for it. We're not doing it, full stop.
Yeah, I appreciate that. And I totally get that you are asked in a number of areas, but it's just, I would have thought that vaccines were a priority to, as far as protecting the individuals, as far as, you know, prevention in the winter, that it might be something that could be prioritized. But Kelvin?
Hi there. Sorry, I can't put my camera on because I'm getting transmission difficulties. But yeah, I think it's important to know the impact of COVID, and especially in care homes. The problem is if it starts up in a care home or in a it could be a real problem. So I think there's a public health element to this as well. So I think what we'll have to do is go away and have a think about this, and maybe we could talk to the LMC about how we come to the solution. But it's a pretty important solution in terms of protecting our population health, really.
Thank you. I'm sure we'd be happy to be part of those conversations and come to a solution that helps all. Thank you. So there's a question in the chat. How do we claim for giving the RSV? Is it via CQRS or FP34s, etc.?
I don't know. I'll have to find out. I don't know the technical details, but it would be in the contract, but I can find out from NHS England.
Thank you. Are there any other questions at all? Is there an item of service, enhanced service fee for this?
For RSV?
I believe so.
Calvin,
sorry, it was me that asked the question. So I can't recall seeing anything about an item of service fee for giving the RSV vaccine.
Yeah, there is.
It is, yeah. My
There
understanding
is.
is that it's paid the same way as flu is paid. So
Great, thank you.
The RSV is an essential service. That's where it differs from flu.
I think it's a similar level of payment, though, Hazel.
Yeah.
It doesn't look like there's any more questions coming through. I think it was a useful and valid point raised about the unfunded work in generating the list. So if we can be part of those conversations, that would be really good. So thank you for that. Hazel, would it be possible to have a copy of the slides to share with practices?
Yeah, that's fine. Emma, so I emailed you about I emailed you yesterday and for feedback. So I think if we arrange a meeting, we obviously need to discuss this sooner rather than later. So I think if we could get a half hour in this week.
Yeah, I'll certainly look for that, no problem.
Thank you.
Okay, well, thank you for coming along today. Oh, Khalid.
Emma, when you send notes out, Hazel's notes, maybe if we could have I think the company have got a video link of how to constitute the vaccine. And it's kind of very different than just giving flu, which is already constituted and everything. So it's worth sending the link out with that as well.
Okay. Yeah, no problem. Okay, well, thank you everyone for joining today. Thank you, Hazel, for coming to share that update. I think it's been useful for practices. And yes, thank you for everyone for joining. I hope it was a useful session for everyone. Next week, we've got the Phoenix programme coming to give an update on all the different schemes and fellowships available to both clinical and non-clinical staff. So hopefully that should be a useful session for all. In the meantime, stay safe. Thank you very much. If you've got any queries or questions, please get in touch and we will see you next Monday. Thank you, everyone.